session. Now I request Dr. Shrinivas JOSHI to speak on intrascleral fixation of the various techniques.
Thank you, sir. At the outset, I would like to thank AIOS and Dr. K.V. Satyamurthy, sir, for including me in his instruction course. So I'll be just playing a few. Oh, cannot play media. Sorry. Okay. So here a few of these intrascleral fixation videos. I'll just show you a few of them. So here this is again the old video where you are just making a marking, you are just using the flaps and dialing out the same IOL. I think this was done by Dr. KVS some long time ago, and then removing that CTR. Since it was a 3-piece lens, you can use a 23 gauge or a 25 gauge instrument, externalize it, and then make a small intrascleral pocket and tuck it inside the pocket. Using a 26 gauge needle, just make a small scleral tunnel and then tuck it on both the sides. So this is what can be done by the without having the trocars or infusion line. Now coming to the next video is the Yamane's technique. Again, you see here this was a dislocated IOL where frag was done in this case, and after doing the frag, now I am using this 30 gauge thin bore needles as was being discussed previously. So these are always better because of the diameter is less, the wound entry size will be less. So I am just trying to do a railroading technique, trying to push the haptic into the lumen of this 30 gauge needle and then use this Bowie cautery, and similarly do it on the other side. Is always challenging to do it on the trailing haptic. Some people suggested to bring it out and then do it, otherwise if it's possible do it, you can do it, but make sure that you don't break the haptic, and then just try to flange it on both the sides and then tuck it back into the sclera. Now this is another case again, as Dr. Guru Prasad sir showed the dumbbell technique. Here I am preloading it into the 30 gauge needle, and then since there is a trap wound there, I didn't want to disturb that. Taken a temporal tunnel which was made, and then slowly bring out one haptic, and then similar way bring out the take inside the other haptic as well, and then bring out both the haptics out, the 6-O-proline outside, and then thread it into the eyelet of these SFIOL. Then flange it on both the ends and then just pull it. Just always make sure that you pull and check, otherwise in the inside in the vitreous cavity it might fall down. So just pull both the ends and then cut it and then just flange it. Now coming to the next set is this is one of the video which I wanted to show you, that 1 week post SFIOL. This was a threaded SFIOL done by my colleague. So what we did was, this is another way, I'm just trying to show it to you. Instead of again explanting and doing everything, just pull and see. If this SFIOL is moving, that means the thread is still connected, and then take a small stay suture, the anchoring suture you can say, and then once you make the anchoring knot, now you cut that main SFIOL knot, then now you pull it back. Now you can see the other side of the haptic is now, the lens is now centered and then tied to that anchoring knot which you had taken earlier. So in this you can see in just 14 minutes this whole procedure was finished, instead of again explanting, redoing and repeating the same steps again and again. Now next is, as Dr. Guru Prasad sir also showed, these are the few of the videos I want to show. A single haptic dislocation that is called as the dangling SFIOL. This was a traumatic case. So again 30 gauge thin bore needles were used, and since the 6-O-proline was already threaded in that suture, I just took the other end of it and passed it inside in the vitreous cavity and threaded it into the eyelet of the SF IOL, which was dangling inside in the vitreous cavity, and then slowly hold the haptic of it and then bring out that end of the suture. Then just flange it, make sure that the bulb is good enough, and then check it. It's always better to check it internally once you go inside, and then slowly remove these 30 gauge needle, cut it, flange it. Now coming to the next set of this is again very recently done, again single haptic dislocation. So after doing a vitrectomy, we can see the remnant of the so here I am using a chandelier and just made a 1 port entry. Cut that remnant on the IOL, whichever is there. Otherwise, what happens is this sutures, since we are doing the dumbbell technique here, this might irritate the ciliary body and cause chronic iritis cyclitis. So here again I am using already a threaded 6-O-proline, and then slowly thread it inside, and then take the other end of it and externalize it. And once we externalize this, again you need to flange, make sure that the bulb is good enough and flat. Then go inside into the vitreous cavity. Can always cross check, double check it, bring out the other end, and then just flange it. Now this is another my last case where again decentered 3-piece IOL. Here I didn't want it to explant it, again a traumatic dislocation. So both the ends were almost in the vitreous, but while sleeping down it used to come up, so I thought I will refix it. Same again, use the marker, and here I am using a 27 gauge. This is since I didn't get a 30 gauge this thing, because I want to bring it out, the haptics, externalizing of the haptic technique. So I use a 27 gauge condemned forceps, not very good because these are the basically ILM forceps. So just bring it out with a 27 gauge root. That's the smallest this thing. If you don't have a 30 gauge instruments, since we don't have it. Similarly, make again a Z track on the other side. Again use this ILM also in a similar fashion, then catch hold of the haptic, slowly externalize it, and then flange it, and then push it back into the scleral tuck. This is the post-op, the previous corneal scar because of the trauma, and the patient is doing really well. So thank you very much for the patient listening. Thank you, Dr. KVS sir, for this allowing
That
me.
was a nice collection of videos and an excellent presentation. Thank you very much, Dr. Shrinivas Joshi. Now, just one question. I have seen a lot of cases where the flange is exposed on the conjunctival surface. Is it okay if we can leave it like that, or
No,
should we cover?
It depends upon how bad is that the flange. If it's a flat, then it usually doesn't erode the conjunctiva. But if it's a triangular or a sharp peaked, then it always keeps struggling, it might come out. So what I suggest is the Bowie heat cauteries, they are always best because they heat it and you get a good bulb like configuration. Earlier we even used that, what is that instrument which we heat it? Heat cautery.
Heat cautery.
The ball point cautery. But that causes a flat like this thing, configuration. Even lasers also, if you use it distinctly, it might turn good. Otherwise, if you have any of the doubts, always make a flap And these all procedures can be done under the flap, and the flap can be closed. You have done such in some few cases. Yeah. And since you make a Z track, usually these goes back. Once you push it, small flange, it
My
usually.
second case, you saw, I didn't make a flap. I made a groove. No,
Hoffman's
groove.
pocket.
No, Hoffman's pocket
Not
was the first case which I showed.
Achha.
A groove, just a groove, and it is
That
an
also
oblique
can.
groove, not a perpendicular groove. And then it goes into the groove, and that itself covers the flange. I think that is a very good option, and for lazy people like me, that is the best.
Best. Thank you.
We have not been talking about the Gore-Tex switches. You know, that has sorted out a lot of problems.
So that is.
So
his,
next talk is on Gore-Tex.
He's the Gore-Tex man, so I didn't. Touch.
No, one more thing. I have seen you doing a lot of these CMT flex lenses. You find them good? I mean,
Yeah.
you also
Sorry, I
conducting
would
a
like
study?
to beg to differ with the anterior segment surgeon sitting here who uses more of iris claw lenses. Rather, it is almost a similar, since you place it over the iris and handle the iris. It is just a very simple technique where you make flaps on both the sides. It has a good T-shaped. Fortunately, I didn't get it right now. Otherwise, I would have shown that video also. Just externalize it. It sits very good. The only problem with the CMT flexes are they are hydrophilic, and sometimes it might break. But over the time, the company just spoke to them. They said that they have improved on the quality of the CMT flexes also. Luckily, till date, I have done almost around 20-30 CMT flexes. None of them have broken. But if you don't hold it properly, that is the very key point here. If you don't hold the exact T, then it will break.
Other concern is that it is much more bulkier, the T which comes out.
Yeah.
Much more thicker than the flange which you create.
Yeah. But these are pretty much stable, sir. If you don't, rather than doing iris claw, I am telling it as a supplementary to the iris claw.
I agree with that. How long it will get exposed? The erosion of sclera. My concern is it is very thick. Erosion of sclera over a period of time. Like, that is what my concern basically. It is relatively much more thicker than the flange which you create.
Correct. Correct. But these are the fixation points, these are more stable than the flange. The tilt, the decentrations and all those things, using the sheen plug images also, we are doing around 100 cases now. We are comparing between all the three techniques, the flange technique, the suture technique and the CMT flex technique. Hopefully in the next meeting I will be able to tell you.
I think the CMT flex is the best, most
Stable.
stable. Because it has got a wider point of
Yeah.
and the anchoring is also much better.
Correct.
Perfect T there.
Correct.
There is no question of stability part.
I think ultimately the patient wants vision. So if you ask me, CMT flex of all the three techniques or lenses that you mentioned, CMT flex gives the least vision to the patient. I don't know the reason. It is a hydrophilic lens. It is prone for deposits. It is prone for developing haze. In my own experience, me and Apurva together have done about 60-70 cases by now, and we have found that it is not so good. So we are now slowly, guardedly doing CMT flex and going back to the other lenses.